everyone from San Antonio. I'm Elia Segui, a breast medical oncologist and translational researcher from Barcelona, but now at Dana-Farber Cancer Institute, and I'm here today with my dear friend and colleague Rodrigo to discuss the updates, challenges, and controversies on triple-negative breast cancer.
Hello everyone, I'm Rodrigo Sanchez Bayona. I'm a medical oncologist from Hospital Universitario 12 de Octubre in Madrid, Spain. I'm really pleased to be here today with Elia discussing probably one of the hot topics now in breast cancer, which is TNBC. And I think this has been a busy year, right, for TNBC. And maybe Elia, we can start discussing about how do we treat patients in the early setting, right? I think now chemoimmunotherapy is pretty standard with the OS results that we recently saw. But the thing is, would you treat every patient with a TNBC early disease with chemoimmunotherapy? Do you see any other regimens alternative?
Okay, so I think that for stage 1, we can start with stage 1 triple-negative breast cancer. We know that for tumors that are less than 1 centimeter, I think that we both agree that we can do upfront surgery and then decide if we want to give chemo, if we do not want to give chemo. We can think to de-escalate maybe in some patients with high TILs. Maybe like we can discuss which chemo do you think it's better if even we go with a TC. That's like the most standard approach of we incorporate carbo in this setting. But I think that a really space where we don't have like clear data, and I think that there's a lot of variability of what we're as oncologists we're doing is the T1C, right? I think like for tumors that are more near the 1 centimeter mark, I think we all feel comfortable with the upfront surgery. But what do you do? Like, what do you think, or how do you approach when you have a patient with a stage 1 between 15 millimeters and 2 centimeters? So like T1C, more like.
Yeah, exactly. I think that's a big gray zone. So probably what I personally do in my daily practice, I try to go for neoadjuvant strategy. I think it's very informative to know if a patient reaches a pathological complete response, and it also helps you kind of stratify in the long term what's going to be the risk for the patient experiencing a relapse. Personally, you may be over-treating some of those patients, because if you go for neoadjuvant, probably you will do sequential polychemotherapy. But we have witnessed recently this San Antonio breast cancer symposium that probably adding on the platinum in the equation makes sense and has a clear prognostic impact. So most of these patients, if you go and you decide to go for polychemotherapy, probably adding a platinum salt makes sense. So,
and do you think, like, what would you favor, more like a dose then ACT plus carbo, or would you favor more like a neopact approach with a carbotaxane and then pembrolizumab in this setting?
Yeah, that's a good question. And the big thing is that there's a caveat that we are lacking head-to-head comparison with all these kind of regimens. I would say that I would try to tailor the treatment depending on the patient. If it's a young female, a fit young female, probably we might be kind of biased to go for a more intensive treatment. But if you have a frail 80-year-old lady, probably you kind of de-escalate the treatment and you prefer to do not so intense, not dose dense, not high intense regimen of chemo, right? Maybe it's not fair because ageism is not fair for patients when deciding for treatment, but I think there's a big need for new biomarkers. Like, for example, what value do you give for TILs in the early setting?
So I think that that was what I was going to ask you, actually. Like, how do you feel like we can incorporate biomarkers here? Like, we have TNBCDX with its like gene expression that combines immune signature plus like tumor cells, nodal status, and we know that probably, like this can help us de-escalate treatment in T1C, but maybe also like T2 and zeros, and maybe even T2 and 1's tumors. Maybe I'm being a bit optimistic. And I do think that TILs we have a huge amount of data of TILs in TNBC showing that they are really have a strong prognostic role. So I do think that for patients with high TILs, which are not that common, but like patients with more than 30%, 40%, 50%, I don't know, like this exact cutoff, I think we can de-escalate. I think one open question is like, what do we escalate? Do we de-escalate the carbo? Do we de-escalate the immunotherapy? What?
Or even no chemo at all. Like, for example, there's a very interesting ongoing trial that's being conducted by SOLTI and Unicancer. It's the academic collaboration. It's the ETNA trial, and in this trial, the small tumors, TNBC patients, depending on the age and the cutoff of TILs, this trial is prospectively addressing the question on whether we can de-escalate even those patients who will not receive any adjuvant treatment at all, or just a combination of just immunotherapy with pembrolizumab, or even taxane and pembrolizumab. So I think this trial will be really very relevant in adding some light on this regard, right? So probably one of the main things is going back to the value of the TILs. We have seen this San Antonio that also the value of the TILs in the residual disease, and I think that's another argument. I don't know if you agree, for going for neoadjuvant treatment, right? Because you have the baseline assessment with TILs, and you have the residual disease, and you can somehow combine both markers. Because what importance do you give to these dynamic biomarkers in breast cancer in general? I think you're a strong believer of biomarkers.
You again stole my question. I was going to what's your thought on the dynamics biomarker? And I think we've seen really interesting data at San Antonio of both mid MRI, and I think that's really interesting. There was a spotlight, and they presented 3 or 4 abstracts with the exact same idea, starting with the carbotaxol pembro and then doing a mid neoadjuvant MRI, and you can see that the radiological complete response in this mid MRI has a really good correlation with PCR, and it's also prognostic for long-term outcomes. So I think this can help us de-escalate. So I imagine, I was actually talking to one colleague before about a young patient with a T2 and 0 triple negative breast cancer, 80% TILs, and she was hesitating whether T2 and maybe some doubts of node positivity, and she was hesitating whether to go with a full keynote 5-2 or whether to try to de-escalate. And we were discussing, and I said you can start with carbotaxol pembro, right? And you have if you have a radiological complete response at midterm, you have high TILs, right? She had also a TNBCDX with low risk score, and then if you have a radiological complete response in this mid MRI, that's amazing. And another tool that I think it's promising, though maybe early, but we've seen really interesting data in San Antonio, is a ctDNA, right? MRD. We have more and more evidence that if you have a clearance of your ctDNA by cycle 2, day 1, then you have much chances of having a PCR, and then as well long-term outcomes. So I think basically combining baseline biomarkers such as TILs, TNBCDX with dynamics biomarkers, MRI, ctDNA, I'm hopeful that we will be able to
somehow stratify the treatment.
And I think another example of a biomarker actually was what was presented just a couple of hours ago, that in BRCA patients, BRCA mutated patients with stage 1-2 triple negative or breast cancer, an approach with combining olaparib, so a PARP inhibitor, with immunotherapy can get to PCRs around 80%. So I do think we're doing progress there.
Yes, indeed. And also the more options our patients have in the early setting makes it even more challenging, more complex on how do we treat advanced disease, right? And it's also, this year has been extraordinarily busy for advanced disease. We just seen in less than 1 year 3 positive phase 3 trials for the first line in TNBC. There's a clear unmet need. How do you see now the current scenario? Because of course ADCs are moving to earlier lines. We saw the data of sacituzumab govitecan, both alone or in combination with pembro, but also datopotamab deruxtecan. So what's in your mind, what would be the ideal algorithm?
So, metastatic triple negative breast cancer, we've all had patients. We know that this is a really bad disease, and sometimes I'm a bit skeptic in hormone receptor positive disease to move everything earlier, but I do think that in metastatic triple negative cancer we lose patients between first and second line and third line, and there's a lot of data about that. So I do feel that an anti-TROP2 ADC will be the standard of care in first line for patients that are PD-L1 positive combined with immunotherapy, though I think that we need to highlight that we don't have a lot of data of what happened with patients that relapse after keynote 522. That will be the most part of the patients in the future. The trial only had like 5% of patients that had received prior immunotherapy. So we really don't know if, we need this pembro, if we don't need this pembro. But I'd say that this standard for the novel metastatic triple negative breast cancer and patients with maybe a disease-free interval of more than 12 months, let's say, I would use the combination of SASI plus pembro in PD-L1 positive. And then for PD-L1 negative, you have two trials that are really similar, but at the same time have like different populations. The Tropium breast trial included patients with really like a short disease-free interval, which was like really good. So we have some data there that I think it's important. At the same time, like the Ascent trial allowed for crossover. So I think both treatments, both trials were positive. Both treatments are good treatments that have proven to have efficacy.
Yeah,
and then, yes, we will have to decide based on patients.
I think that's good news for patients, right? To
Exactly.
be able to choose among different options, because even both drugs, the profile of the safety profile is fairly different. For SASI, you can expect more GI toxicity, more hematological toxicity. For datopotamab, we have eye toxicity and the mucositis. So, for example, let's say you have a 50-year-old postmenopausal female with a de novo stage 4 PD-L1 negative tumor, TNBC. How would you discuss with the patient the pros and cons of both drugs? How would be your approach?
Both drugs, I would say both drugs have have efficacy. We know that. I would discuss the schedule. For SASI, you do have to come 2 weeks on, 1 week off, and that might be a problem for patients that live farther away. That's a thing that we see here in the US. We don't see that much often in Europe, though. And datopotamab, it's only like a every 3-week schedule. I would discuss, the safety profile. You have more chances of neutropenia and GI diarrhea toxicity with SASI, which, usually on my experience for young, fit, no overweight patients is not a big deal. But then on the other hand, with datopotamab, you have these oral mucositis, which can impact the quality of life. So you need patients to be super motivated and engaged and do all the prophylactic measures. So maybe if you think that the patient is not going to be adherent to the prophylactic measures, maybe you can switch to the other one. I think it depends, and I think it's it has to be an open discussion with patients.
Sure, certainly. And do you see any role in sequencing one ADC after another?
So I do think that we have now maybe not prospective data, but quite a fair amount of retrospective data that shows that if you're using the same payloads, in this case, with the same kind of payload, which in this case would be there's cross resistance, and that ADC2 in most cases it does not work. Maybe we will be able to figure out some biomarkers to select some patients that may still derive benefit, but I'm not currently using ADC after ADC, immediate. You can opt for a sandwich, but then again, for triple negative disease, I think that we have to highlight is that we do not have a lot of treatments, unfortunately.
Yeah, many options.
So, how do you approach a patient that has progressed to both an ADC and immunotherapy?
Yeah, at the end of the day, probably you're in many options, and even if you sequence, the dropout rate of patients that you lose one line after another is nearly 20-30%. So unfortunately, and there's a final question, what's the relevance you give to brain mets in this algorithm? Because probably we know we have some ADCs that have proven to have a very high intracranial activity, like TDXD, for example. Do you see, I'm fully aware that the numbers are small numbers for TNBC and TDXD. So would you prioritize maybe TDXD in this situation, or?
I think that's a great question. Actually, I think both DATO and TDXD have maybe stronger evidence in the brain mets, so that's definitely a thing that I would consider, and I would lean more forward, lean towards either DATO or TDXD in this setting.
Good. Do you have any final remark from this San Antonio for TNBC?
Yeah, I mean, I think my final remark on TNBC is that we do have like a high unmet need in patients that have an early relapse after keynote 522, and as researchers and clinical researchers and translational researchers have to like start studying this to come with a solution.
Awesome. So I really enjoyed the conversation, and I hope that you at home really also took the advantage of listening to us and learn a lot from this San Antonio symposium. I think 2025 has been a very busy year for TNBC, but as Elia mentioned, there's still a big unmet need, and we still do need to do more research for our patients. So thanks, Elia, and
Thanks.
thank you all, and see you in the next video of SOLTI Young. Thank you.